Well, it looks like they're pretty stabled out here. We just have one more council member we're expecting to have join today, District Attorney Whitney, but she might be running a little behind. So why don't we just go ahead and get started? Oh, looks like we're pulling up the presentation. Thank you to my team. So welcome to, oh, go ahead.
I'm sorry, I didn't mean to interrupt, but I just want to let you know we do have a quorum.
Oh, thank you, Monica.
Whitney.
Thank you. So welcome everybody to our full council meeting here at the Council on Criminal Justice and Behavioral Health, our first one of the year. My name is Brenda Graylish and I am the Executive Officer of CCJBH. And I would like to quickly turn it over to our Secretary, our Chair, Secretary Allison, to say a couple quick welcoming remarks.
Thank you, everybody, for your time and attention today on this Friday. I always say, why do we do this meeting late on a Friday? So I'll challenge Brenda to look at other options for us in the future. And maybe not till next year, but I'll let her try and figure all that out. I know that, everyone calendars their time accordingly. A lot has happened since we met last. I mean, it was only a month ago. I swear, it just seems to fly. It's felt like yesterday as I'm reviewing the minutes. But I just want to say a lot is happening within the department. We are also a lot of exciting things in our budget change proposals that are in front of the legislature next week, and so we're hopeful there. That we can really support our population upon release as well while they're in institutions. When I look at the data, it was highlighted at the last meeting that unfortunately a fair percentage of people pass within the first 2 weeks upon release. Those are oftentimes due to overdoses, and of course violence unfortunately plays into that as well. But what I will say, I with all of our medicated assisted therapies and all that we're doing within the department, we're hoping to see those numbers reduced drastically. I think everyone knows CDCR is currently struggling with the Omicron outbreak within our institutions. We have 6,150 for the population. With active cases of COVID. And so we have about 4,100 staff. Fortunately, we don't have the hospitalizations that we did last year. And so we're very hopeful about that. And then of course, we're still working with returning home well, and we're hopeful to continue that funding as well. We're currently using it now. We also have ability if somebody releases while they're in their quarantine period to be able to take care of that as well, so we're not impacting the community. So a lot has happened. We have 81% of our population vaccinated, 71% of our staff. So we've made great strides here, but it's always very, very it's a difficult time. And I appreciate everyone's support as we manage through this. So, and I know state hospitals are impacted, and my sweet friend Stephanie is on our committee as well. And I know how hard it is for me to carve out time. I'm sure it's hard for her, especially trying to manage the COVID outbreak. So I really want to thank her for her time and attention, as well as everybody on the committee. So with that, Brenda, I'm going to turn it over to you.
Okay, thank you so much for all the words and just reminding us that we are still in a pandemic and so much going on, but the work continues despite all of that. So many people doing great work for our population. So thanks for the opening. With that, let's just do a quick roll call for everybody, so we have that for the record. I will give a name, and if you can introduce yourself and your affiliation, we will go ahead and get that recorded. So, Secretary Allison.
Present. Kathleen Allison, Secretary for CDCR.
Thank you. Chief Deputy Chris Edens.
Hi, present. Chris Edens, Department of State Hospitals.
Thank you. Council Member Danitza Pantoja.
Present. I'm from the Antelope Valley Union High School District.
And Council Member Anita Fisher.
I'm present. I'm family member representation appointed by Governor Newsom.
Great. Director Hobson.
Hi, present. Behavioral Health Director, Plymouth County, and appointed by Governor Brown.
Great. Retired Chief Mac Jenkins, who unfortunately was not able to join us today. Dr. Cooler.
Good afternoon. Jim Cooler, Special Consultant, Behavioral Health, Department of Healthcare Services, representing Director Doss.
Great. And Judge Manley.
Judge Stephen Manley, appointed by the Chief Justice on behalf of the courts.
Okay. And District Attorney Tracy Whitney. I don't think she's had a chance to join us yet.
Hello, I'm here.
Oh, you are here. Oh, wonderful.
Yeah. I'm from the Los Angeles County District Attorney's Office, and I was appointed by the Attorney General.
Well, welcome. Thank you for coming today. Okay, next slide, please. So just a little housekeeping. This meeting is being recorded. When it comes time for public comment, please use the raise hand feature to make a comment, and you'll be placed in line to comment in the order in which the request your hand was raised. And when it is your turn to comment, our host here at CCJBH will unmute your line and announce your name. And then we ask folks to keep their comments to 3 minutes or less. And Monica Campos will help us out here with that today and keeping track of time for our public comment. As always, if there are comments that we don't have time to capture today or that you think of later on, we always have our CCJBH email account at ccjbh@cdcr.ca.gov, where we welcome you to share your thoughts with us. Next slide, please. Just a note on virtual council meetings. So AB 361 last year authorized these virtual meetings for the Bagley-Keene Open Meeting Act for us councils that are subject to that until January 31st, 2022. However, Executive Order N-1-22 extended that to April 1st, 2022. So we as a council will continue to meet virtually in accordance with the mandates. So just want to let everybody know. So for obviously we were covered for this meeting, but we weren't too sure about our February work group meetings, but those will also be continue to be held virtually until otherwise we hear otherwise or the date expires. Next slide, please. So to go over the agenda, we've already done our welcome and introductions and our roll call. Then we'll move to approving the December council meeting minutes and have public comment. And then we'll move to our CCJBH business meeting. So the first half of our meeting will focus on our 2022 priorities and our meeting schedule. We can also talk a little bit about that Friday meeting, afternoon meeting question that Secretary Allison just brought up. We can talk a little bit about that and see if we want to make some changes. Then we will have a public comment. Next slide, please. And then we will be welcoming the Department of Healthcare Services to present to us today on their the latest report they just recently released about a couple weeks ago, a week and a half ago, assessing the continuum of care for behavioral health services in California. This was of great discussion when we had our last meeting in December, where there was great interest by our council members to really understand what the gaps are in services across our behavioral health continuum and how many of the investments that are being made to date and proposed will be able to help fill those gaps. And then we'll open it up again for council questions and discussions and public comment. And then we have a few little announcements and then we'll adjourn for the day. Next slide, please. So moving along to our council meeting minutes, do we have a motion to adopt the December full council meeting minutes?
So moved.
Is that Director Hobson?
Second, Judge Manley.
Okay, sounds great. Then we will take it for, public comment? First public comment. Do we have any?
I don't see any hands up, Brenda.
Okay. Let's take a roll call vote then. Secretary Allison.
Aye.
Great. Chief Deputy Edens.
Aye.
Councilmember Pantoja.
I'm abstaining.
Okay. Councilmember Fisher.
Aye.
Great. Director Hobson.
Aye.
Dr. Cooler?
Aye.
Thank you. Judge Manley?
Aye.
And District Attorney Whitney?
Aye.
Great, motion passes. Thank you. Next slide, please. Okay, so moving along to our 2022 priorities. So this is kind of continuing the discussion that we started last meeting. Next slide, please. So we're seeking, we as a council staff got together and started planning out 2022 priorities late last fall, and looking at all the work that we've been doing and what's kind of on the horizon, are suggesting to continue certain projects, which include examining services. So looking to look at all services across all disciplines related to the behavioral health justice involved population. In particular, so that's criminogenic interventions, as well as behavioral health treatments and social services, housing and the such. But also really focusing on CalAIM, because CalAIM is started January 1, 2022. That's DHCS's large initiative that we had a presentation on back in October. And so CalAIM is implementing, it started for a portion of the proposals went live January 1, 2022, with additional rollouts moving along throughout the year, July 1, 2022 and on into January 1, 2023, with what we're mostly looking at, which is the justice involved proposals, but also continuing to track the progress of the behavioral health continuum infrastructure program, diversion programs, and really just looking across the board for those wonderful programs and strategies on how to best engage the behavioral health justice involved population and deliver high quality services. In addition, like I was mentioning, housing, continuing to work to advocate for the prioritization and development of housing for our population of focus. And this includes, for those that may not have been tracking, the Homeless Coordinating and Financing Council just changed their name as of January 1st, 2022. To the California Interagency Council on Homelessness, and our very own Secretary Allison is a member of the Cal ICH, and they had their kickoff meeting yesterday. So we are continuing to track that work and their action plan, where Cal ICH is looking to start a justice involved work group in fiscal year 22-23. So continuing to track those efforts and weigh in, as well as just collaborating with Cal ICH on various projects that they're working on for the justice involved population. And that's both at the state and local level, as well as implementation of the recommendations in our housing report that we did with the Council on State Governments Justice Center. So as you may recall, we had the launch of the report last year, which is which pertains to addressing homelessness for individuals releasing from jails and prisons. And that has rolled into a webinar series that the Council on State Governments Justice Center and our team kicked off last month in December 21, pardon me, and is going to continue until April of this year. And then just continuing our work to promote cross-system education and collaboration. So really just working to make sure that there's advocacy and education about the unique needs of the justice involved population as it pertains to housing. And then, as Secretary Allison mentioned, returning home well and continuing to promote and track those efforts as well. Next slide, please. Also with workforce, so we've talked a lot about this in our council meetings and work group meetings, establishing and expanding the workforce across multiple sectors. And we've talked about that forensic peer support specialist classification. And I know in the behavioral health sector, there's been quite a bit of work being done on the general peer support specialist classification. And we've been tracking those efforts, and those will be rolling into a forensic peer classifications discussions. And so we'll continue to track that on the behavioral health and the behavioral health sector, and see how that might translate and be useful for other sectors such as criminal justice and housing and social services. In addition, the Healthcare Access and Information Department, formerly the Office of Statewide Health Planning and Development, under the behavioral health, the Kids Behavioral Health Initiative, or the Children and Youth Behavioral Health Initiative, that's being led by the California Health and Human Services Agency. HCI, as they're called, is receiving, or they received funding to expand the workforce for justice-involved youth. But the idea is that expanding the workforce for justice-involved youth will also expand just workforce for justice-involved populations in general. So we've had the fortune of connecting up with HCI to begin some discussions to see how we as a council could be helpful to provide expertise as they work to build out efforts to expand that workforce. In addition, some thoughts that have been discussed in this council meeting, I believe, I know Chief Jenkins isn't here today, but he's brought up some ideas in terms of presentations having to do with cross-education between mental health professionals and just the justice system, so that folks who are working in these different sectors know how to talk with one another and understand each other's systems. So there's been some work that's been done by Dr. Jeff Twitchell, who's I know presented here at our council before when I was a council member, has done some recent work in that area. So we could potentially have that as presentation. In addition to workforce, really continuing to focus our efforts to examine data. We have our Public Health Meets Public Safety project with the Council on State Governments Justice Center. We have a contract in place to develop, to kind of marshal publicly available data and try to put that into a dashboard that is kind of a one-stop shop for people to be able to see what publicly available data there are in, regarding the behavioral health justice involved population, as well as expanding efforts on our Medi-Cal utilization project. So this is the project where we take CDCR release data, people coming out of prison, and match it to Department of Healthcare Services data to examine Medi-Cal enrollment and utilization across the different Medi-Cal delivery systems, particularly for those who have identified mental health and/or substance use disorder needs at release. So continuing to build out those analyses. Unfortunately, we've lost our research scientist late last year here at the council, but we are about ready to hopefully bring somebody new on board within the next few weeks, so we can continue those efforts. In addition, continuing our work for community involvement. So we have our work group sessions where we talk about a variety of topics, and I'll get into some ideas for topics in a couple of minutes, but also proposing to continue on this year with our 2 work group meetings that meet bi-monthly. And then also continuing our regional lived experience projects. So we had them present at our December meeting, so we will continue with those efforts as well. And then education. So continuing to host the special events across the different sectors. So for example, this past year, we would do May's Mental Health Awareness Month, or in September, we do Recovery Awareness or Suicide Prevention Month. So any of those activities we would seek to continue in this year, just to keep promoting those issues for as they relate to the justice-involved population with behavioral health needs. Next slide, please. And so those are continuing projects. And then as far as future projects, a couple new things to put on the project plan that we're suggesting is doing activities to celebrate our 20th anniversary of CCJBH by reflecting on our accomplishments. So as of this year, we are 20 years of CCJBH. So I know, right? The legislation was passed in 2021, but the council didn't start meeting until actually August of sorry, it was passed in 2001, and the council didn't start meeting until August 2001. So 2002, sorry. And so really excited to be able to share and celebrate our 20th anniversary. So we're looking into some potential activities that we can do for that. And in addition, just in going through a lot of our records, we also had our best practices awards. For those council members who have been around for a while might remember our best practices awards, and we had put them on the back burner for quite a few years. And so I wrote a memo to our council members that's published with all the meeting materials today about revisiting this idea of reinstating the best practices awards by working this year to develop a process to reestablish it, to select model programs that really fit and exemplify what we're looking to do as a council. Next slide. So with that, I'll open it up to council member questions or discussion, reflection on kind of these broad topics for our focus areas for 2022. And then we can get into some more specific ideas for what we would do in our meetings in a minute. But just in terms of the broad brush strokes, council member reactions, please. Is that in line with what you would expect, or is there anything missing?
I think it looks like you've really thoroughly covered it. Thank you.
Thank you.
Brittany, I thought it was going to be because it's a Friday afternoon.
It's just incredibly good work. It's easy to accept it, and it builds a great frame for us to build and take a look at issues.
Hey, thank you. Okay, so it sounds like this is in line with council member priorities.
It's very exciting, Brenda. And I know the other stuff that you're working on in the background. I know you're anxious to share with the committee. And so I just want to thank you for your leadership in this space. You've been amazing to take charge. I always say as a leader, I'd rather have to pull somebody back than have to light fire. And Brenda's one that I definitely don't need to light fire because she's very ambitious in this space and trying to really make a difference. So thank you for your leadership, Brenda.
I appreciate it. Thank you so much. Okay, fantastic. So it sounds like we're on a good track, a good direction for 2022. Let's get to the next slide. So maybe this is where we can open up that discussion. So what I wanted to do is talk to you all about the full council meeting dates and then some ideas for some the bi-monthly work group meetings. So we'll start with the full council meeting dates, and I think we'll start with the idea of meeting on continuing to meet on Fridays from 2 to 4:30, or as Secretary Allison was mentioning in the beginning, revisiting that if we want to change that date or the day of the week or a time. And I'll just give you just a little background in history. We used to do these as 2-day meetings, 2 full-day meetings. One was like work groups on one day, and the second was like a council meeting, and it was just too much. And so that's why we really condensed it into the 2.5-hour council meetings. And so it seems that the 2.5-hour quarterly meetings are working well. Please state otherwise if you think differently. But if that is the case and we want to just revisit the date of the week, or even if we want to do it earlier in the day on Fridays, I'm just not quite sure. I was a council member when we landed on this, so I couldn't remember why we picked this day of the week and time.
And it was only a suggestion for me, Brenda. If it works for everybody else, I'll manage accordingly. I just, I give you a bad time, but it's certainly, and I don't know if we need like a survey of the council. We're really kind of putting people on the spot. Maybe I could suggest that your staff send out kind of a survey on preferred days and times, and then we can make.
We can do that. We can certainly do that.
Suggestion.
Okay.
But if everyone tells me right now, no, this is really the best time, we picked it for a reason, I will just quit my complaining. I promise.
Oh, it looks like
I really
Judge is
like the
talking.
idea of the survey. I like that idea. Yes.
Great.
Yeah, survey's fine, but this is kind of a fun Friday for me. I don't know.
Tony? Oh, go ahead, Judge Manley. I'm so sorry.
Yeah, I'm just going to give my input. In my work, I have calendars every day. And this is a time that works. It's just very difficult. We are short of judges. We have backlogs of cases because of COVID, and to suddenly change at a time like this would be really difficult for me personally, because not personally, but because of the obligations I have to be in the courtroom to hear cases. We are hundreds and hundreds of cases behind. We haven't brought cases to trial. Our entire court is and every court in California is under pressure. I mean, we've had to close in the last few weeks the courthouse to the public because of Omicron, and we are just opening it again now. And that it's just further evidence of how we are building up a backlog of cases that we really need to move through and to provide the best we can in dispensing justice from the bench. And it just makes it difficult to suddenly change at this point.
Okay, how about we do a little hybrid approach? Oh, okay, go ahead, Secretary.
Oh, no, absolutely not. I mean, obviously Judge Manley's time is a little bit more valuable than mine. And so I'm certainly okay. And I don't know if you want to take it to vote now and we can do it, or just be done with it and leave it alone, because Tony's good and Judge is good. And I'm just like, because and honestly, by Friday, I'm so tired. That's all.
No, I
but I'm
agree.
sure Judge Manley's tired as well.
I don't think you're alone in that. I don't think you're alone in that.
Unless anybody has anything, that Judge Manley makes a really valid point. And I know that he's been a valuable member of this committee for a long time. So I'll just.
Well, what we can do is just kind of maybe keep it at the time we have now, and maybe just monitor it. And we could always survey later on, and maybe when things calm down with COVID, maybe in the out year, we can revisit later on this year. And we don't need to take a vote on that right now. We'll just take a vote on full priorities. So, okay, I'm glad we had this discussion though, and I'm glad you raised it because we haven't talked about it in a while. So I'm glad you raised it, Secretary Allison.
And Judge Manley's got me beat, so it's all good.
How do you compete with court calendars? So, okay, fantastic. Well, thanks everybody for the thoughtful discussion. So in terms of meeting topics, so we have our meeting today, which we have DHCS presenting their behavioral health assessment report. And then we have already pretty much tentatively closely locked down on April 29th, the presentation on Sacramento County's Substance Use Respite and Engagement Program, or SURE program. And I mentioned that a little bit at the last meeting, where this is really taking individuals who law enforcement officers come into contact with in the community, and instead of bringing them into jail to book them, instead taking them to an alternative location, thus avoiding a booking, and connecting them to this alternative location where they can be received and connected to treatment. And so really exciting to have them agree to present for us. And then haven't got quite particular speakers locked down for the out months, so July on in the latter part of this year, but thinking tentatively in July, maybe we can have a presentation or two on workforce. So again, like I mentioned, HCI is doing a lot of work, which is the Healthcare Access and Information Department, is doing a lot of work for building out workforce, behavioral health workforce in general, but in particular for the justice involved population, which is super exciting because it's a recognition that there's this particular skill set to address the complex needs of our population, as well as potentially having a presentation by Dr. Twitchell on preparing mental health professionals to work with justice involved clients. And then for housing, revisiting some of the efforts that are checking in on some of the efforts that are going on with housing. We could look in on returning home well again. We could hear from Department of Social Services and Healthcare Services on the continuum of care expansion for expanding boarding cares, as well as what they're seeing with the submissions for the behavioral health continuum infrastructure grant that DHCS will be awarding throughout the year. And then in December, potentially, we haven't talked about juvenile justice in this work group or in this full council group in some time. So we put it on as a December item that we could revisit and potentially look at some model programs for juvenile justice. So I'll just pause real quick there, just in case some thoughts.
Can I suggest we ask Julie from
Cal ICH?
Yeah, to
Yep.
maybe do a presentation on the progress that they've made. And there was already progress being made, but now that there's a new collective group working on things, and I know you're working on that with her, but I think by October they'll have something to share.
Yep.
I'd also like to suggest maybe at some point in time that maybe, I don't know, have you had a presentation on CDCR's integrated substance use disorder treatment to include the Medicaid assisted therapy program that we have?
We have had ISUDT come and present, but we could put it on for a potential update, for just so that we can track progress. That's a great one. I've noted it. Thank you. Other ideas?
Maybe,
Well,
go ahead.
Oh, go ahead. Go ahead,
Dr.
Jim.
Meth. Maybe just a connection in the April meeting to the 988 system that's being put in place that is also taking a look at trying to divert some people from criminal justice to behavioral health.
Oh, great idea, Dr. Cooler. Yeah, because it's Jonathan Porteous, who also does WellSpace, is one of the suicide prevention lifelines that'll be converting over to 988. So that's a good twofer.
Yep.
Great, got it. Thank you. Judge, were you gonna say?
Yeah, I was just going to suggest, maybe you've already covered this, but I really think the Cal AIM issue is a critical one that we need to get really on top of early, since we have, less than a year to really get this into action, and I think it's complicated. And I really think we should devote some quality time to it, because I'm very concerned. And what I'm seeing is that for those counties that have been able to lower the populations in the jail, the number of individuals in the jail during COVID, number one, the numbers have started to go up, but more disturbing to me is the proportion of individuals who are in our jails who are the population that we are focused on is increasing. And it's not just in my county. And I think that Cal AIM gives us a real opportunity to do something about that. And it to me, it can easily slip away. It requires, what I have found in my own county and in talking to judges in other counties, it requires a great deal of coordination and collaboration and willingness to change systems that have been in place for a long time, that really, we all resist change, but it's really difficult to make some of these changes. And I think that our focus on that should be a priority. We should involve the sheriffs. I think they're critical to all of this process, as well as the managed care programs and behavioral health, so that we can do everything we can to encourage a collaborative and excellent outcome to what I think is a very well-designed program and very well intended, and an incredible opportunity to expand treatment capacity, and most importantly to me, to create a process where there can be real engagement with an individual who's in custody, and then maintain that engagement and re-engagement when they're out of custody and treatment, so that they don't come right back. And that's what I've noted over the years. It's still true today. So I would just urge that we put that somewhere in our agenda.
Great. And Judge, I do have, I haven't gotten to the slide yet, but for our diversion and reentry work group, one of the whole person care pilot counties that is actually doing it right now. So for the justice involved population. So we will have that. Is there anything, so we have a presentation that's scheduled for next month for Riverside County to talk about their whole person care pilot. Now, as of January 1, they had to go live with full CalAIM, enhanced care management, community supports. So Judy Nightingale will be here to talk with us about how Riverside County did it, to kind of bring it to life for folks and get a real concrete example of what enhanced care management is, what it looks like, what community supports are, what they're offering, and all of the work that Riverside County had done to connect with justice partners, particularly parole and probation. Is that sufficient, or is there something else that you're looking, that you have in mind?
I just think it's something the full council should be involved with.
Okay. So the full council meeting. And we will be recording those webinars too, to make them available for folks, because I know there's managed care plans who are interested in hearing what's happening, and different county justice partners. So, okay, we'll look into that and figure out what's a good way to lift those models up statewide and to the full council. Okay, thanks, Judge. Any other ideas? Okay. All right, moving along to the next slide for our juvenile justice work group. Our juvenile justice work group meets from 1 to 3, also on Fridays. So I assume that would probably be still a good time to keep. We have already solidified our presenters for the February work group meetings, and we at CCJBH, our staff, will be presenting an update on the Juvenile Justice Compendium and Toolkit. So a brief update on where we're at. We'll just close the RFP by that time, so we can give an update. And then also the Office of Youth and Community Restoration will be here to present. They have a new executive director, Karen Lucero, who was a former judge in Santa Clara County, Judge Manley's counterpart. And so very excited to have her join as the executive director of Office of Youth and Community Restoration. And she will be here on February 11th to talk about her vision for OYCR. She's very passionate about our youth population, is at Promise youth, and also our justice involved youth. And then from our 2021 work group discussions, which also had rolled into our ledge report recommendations, looking to do some focus on substance use disorder and mental health services on school campuses for justice involved youth. So we're looking for some great models out there. We've reached out to probation and CBHDA, and also Dr. Pantoja on our panel to find out if there's some model programs out there that we'd like to lift up. And that came from our discussion last June, where there was a focus on youth who are justice involved, who aren't getting easy access to services. So for example, really services might be across town and very difficult for them to get to. And so how do we develop programs that make it very easy for youth to access the behavioral health services that they need. And then similarly in November, another topic that came up in our June juvenile justice work group meeting was the juvenile hall to school transitions. And so that is another area that we'd want to talk about in terms of how credits move between the two. And so we optimize the chances for success for our youth. So again, looking for model programs where that is working well. And then in August, our legislative report recommendations that we typically do. And is there something, I think that's the last of those meetings on that end. So in terms of juvenile justice, any other ideas that folks might want to throw out or be interested in? The council members? Okay. All right. With that next slide, we'll talk about the diversion and reentry work group, again, 1 to 3 on Fridays. So February 18th is our next one, and it's not TBD anymore. We do have confirmation now from Riverside County. Again, they are one of a handful of counties that focused on the justice involved population as part of their whole person care pilot. So they've done a lot of work in this space and are very excited to share what they've learned and how they've operationalized their program over the years and what they've done to prepare for the transition to CalAIM for enhanced care management and community support. So I'm really excited to have Judy Nightingale from Riverside County come in and talk about that with us. And so, like I said, we'll be recording that. And I know there's lots of interest, and I'm continuously throughout the months having conversations with individuals who are interested in really understanding how enhanced care management and community support works. And so being able to have that video handy to send to people will be, I think, a great resource as more providers and more counties come up to speed and managed care plans prepare for the launch of the justice involved CalAIM proposals January 1st, 2023. And then in May, focusing on diversion. So that's both misdemeanor and felony diversion. With the passage of SB 317, there's been a lot of focus on misdemeanor diversion because now there aren't going to be misdemeanor ISTs anymore. And then continuing on the discussions with our partners and fellow council members here at the Department of State Hospitals on felony diversion. So we have our work with the Council on State Government's Justice Center, who is doing learning collaboratives right now with counties, many of whom are DISH diversion counties, to really expand the use of diversion. And then also just tracking the expansion of DISH's work from the DISH Incompetent to Stand Trial Solutions work group, and so many of the great ideas that came out of that work group and the new projects that DISH is proposing as a result. And then in August, our usual legislative report recommendations discussion. And then in November, this is one idea we've been approached by entities to talk about outcomes, how to improve outcomes through pay performance contracting models. It's come up in this meeting as well a few times. So just put that on as a potential meeting topic as well. So opening this up for diversion and reentry work group meeting topics. Does this sound like a good plan, or are there any other ideas for things that council members might be interested in us working on?
So Brenda, this is Tony. I'd like to hear how other counties are handling SB 317. There seems to be some confusion on the ground level as far as who's responsible for what, right? I mean, if you're a county behavioral health and you're working closely with the courts, there's some nuances to this bill that puts stuff on county behavioral health's plate without any funding. And so I just like to hear what some other counties are doing.
Okay.
I would agree with that. I was going to raise that as a question if that was going to be the focus on May 20th.
Yeah, the idea is to do some, but these are good concrete ideas for what you're interested in hearing about.
Yeah, we know, at least with DSH, that some of our DSH diversion funded programs are basically serving as that referral source for the 317 referrals. Not the source, but the referrals are going to these programs. lacking any other sort of infrastructure or point of contact.
Mm-hmm. Yep. Okay.
It's a major issue. I think that deserves
Some discussion.
and because the legislature gave very, very little guidance as to the alternatives that they give judges. You know, for example, AOT, a direct referral from the court. AOT is always assisted outpatient treatment, I should say, Laura's Law. That's always been considered a civil proceeding in the courts. And to move criminal justice clients into that process is new and different. And there's no guidance from the legislature. I know in my county, we are implementing SB 317 and the change for misdemeanors right now, and doing it in a very different way than I'm sure other counties would do it. But I think it's something we should discuss.
Okay.
I agree.
Great. Yep. All right, so we will work on putting, you know, a couple presentations together to talk about that, or some sort of a facilitated discussion on it. Okay. Any other thoughts? And I should say too that, you know, just because this is not necessarily set in stone, and, you know, if council members or other things, other priorities come up, then we can shift around. But these are some potential topics that we wanted to at least sketch out, so we had a game plan for 2022, something that we're working for, and we can tailor it or make changes if needed. Okay. All right, next slide, please. So I think we've done our council member questions and discussion. I did that after each one. So I think we're ready to move to a vote. So let me get my voting sheet up. If I can get a motion.
I move we adopt the priorities outlined in the work plan that's been presented today.
Thank you. And a second?
Second. This is Chris Edens.
Chris, and we'll do a vote. Oh, I'm sorry, public comment. I always forget the public comment. Let's open it up for public comment, please. Any public comment? To make public comment, you can use the raise hand feature. Should be at the bottom of your screen.
There is no public comment at this time, Brenda. Oh, never mind.
Oh, we had one person, looks like on and off. Oh, maybe just testing out the, oh, we do have one.
There we go.
Okay,
Oh,
Ms. Canson. Okay. Mrs. Canson. Ms. Canson, I think you've been unmuted.
I'm wondering if there's any way a family member can get, like my mental health son, some treatment in a crisis, just escalated trauma into a DSH. Does it have to go through a court process, or can a family member initiate that happening?
I think we would have to follow up separately with you on that. And so right now we're taking public comment on our CCJBH priorities, but Ms. Canson, we'd be happy to talk with you offline on that to be helpful. Okay, thank you. Arlene Hip, looks like one more.
Arlene, you should be able
Yes,
to.
good afternoon.
Oh, hello.
Good afternoon. This is my first time attending, and I'm so excited to hear about the work that you are doing, because I've worked with the homeless and housing prevention, homeless prevention, and also to see that you're including the workforce developments. One of my questions, I guess, is there's a community CERF for the workforce development, and I don't hear anyone talking about any training, because I heard the judge mention about the return and, you know, the recidivism. And so I'm wondering about how much emphasis is being put on workforce development so that there is not a return to recidivism, and also to increase opportunities for housing. So I'm curious about like the intersectionality of these particular areas along with mental health, because they, you know, they all do intersect. Thank you.
Thank you. And appreciate that. I'm not quite sure what CERF stands for. Maybe we could do a little Googling to find out, unless you want to share that with us. Or if you'd like, we have our email address at ccjbh@cdcr.ca.gov, and we can pop that into the chat for you. And if you want to send us some information, we'd be happy to look into it, and we could think about it for our workforce present day that we would be dedicating to workforce. Thank you. Any other public comment? Okay, hearing none or seeing none, we'll go ahead and take a vote. Secretary Allison.
Aye.
Okay, thank you.
Sorry.
Director Clendenin. Oh, I'm sorry, Chief Deputy Edens.
Aye.
Thank you. Councilmember Pantoja.
Aye.
Thank you. Councilmember Fisher.
Aye.
Thank you. Director Hobson.
Aye.
And Dr. Cooler.
Aye.
Judge Manley.
Aye.
And District Attorney Tracy Whitney.
Aye.
Okay, motion passes. All right, well, we are a few minutes early for our 3 o'clock presentation of the Department of Healthcare Services. And I don't think we have Tyler Sadwith on quite yet. Monica, has Tyler joined us yet? I know he was going to try to sneak away early. I don't see him.
Not yet. He's not
Okay.
on this yet.
So what we'll do is give everybody the gift of a few minutes of time. We'll go, we'll stop the recording, take a little break. And if we could have everybody back here at 3 o'clock, about a minute here. If our council members want to come back. If you can hear me.
So Brenda, how many of us have registered for the forensic conference in April?
I'm going to say a handful, 4 or 5.
Okay.
Monica, Liz, do you know off the top of your heads? I think Liz was the one that processed it for us. I think it's like probably Mac, you're going, right?
Yeah.
Yeah. Me, I'm facilitating a panel.
I think the judge is presenting as well.
Probably judge is going to, yep. We end up presenting, that's what we do.
Sorry, I couldn't get myself off mute. Yes, we are processing the conference fees and working with accounting to get all the travel and everything going for that.
How many council members are attending?
I think it's 2. Paige, do you remember? It is 2, right? It's just it's
Yep.
Chief Jenkins and Tony.
Yep.
And then Judge and I are
I
presenting.
want to be there.
Yeah, he'll be there. He's just under as a presenter.
I didn't know we were paying travel fees.
Well,
I
Well,
just
we-
wanted to mention, I'm sorry, we were going to check back with Tracy to see if she wanted to attend as well. So I'll be checking back in with some of our council members for that.
And we could do that with Judge too. So, okay, sounds good. All right, everybody. So it looks like it's about 3:01, and Tyler Sadwith from the Department of Healthcare Services is with us. And so really excited, Tyler, thank you tremendously for taking time out of the busy DHCS schedule to be here with us today to present to us on the recent gap analysis that was recently commissioned by DHCS to assess the continuum of care for behavioral health services in California, as well as to talk about many of the investments that are being made or have been made and are being proposed that would be able to help fill those gaps. And so I know Dr. Pfeiffer was looking forward to being here today, but wasn't able to. She's been pulled in another direction, but really excited to have you here in her stead to be able to share this really helpful information with us. And I think it's just, I can definitely tell you from our December meeting, this is a really hot topic with our council members. So thanks for being here today. And I will turn it over to you to impart your wisdom on us.
Great. Thank you, Brenda, and good afternoon, everybody. As Brenda mentioned, my name is Tyler Sadwith. I'm Assistant Deputy Director for Behavioral Health at DHCS, and I will try my best to fill in Kelly's shoes here. So I think I really look forward to sharing information in this assessment, which is designed to really serve as a foundation for the steps that DHCS and this administration are taking to expand access and improve the delivery of healthcare prevention and treatment and supportive services through ongoing initiatives as well as through forthcoming initiatives. So just to sort of provide some context, DHCS in collaboration with stakeholders produced an assessment report on California's behavioral healthcare system. This is available on our website, so I'll spend some time today walking through the context for that assessment, the findings, and the opportunities that the assessment has highlighted. And of course, as always, look forward to hearing the thoughts and perspective of council members. If we could go to the next slide. So just by way of an agenda, I'll provide just some background and context regarding the assessment itself. Then I can walk through a framework for the assessment that really envisions a continuum of person-centered behavioral health care, which was used to guide sort of the data gathering as well as the organizational and reporting efforts for the assessment. I'll highlight some of the key initiatives that are being planned and implemented to better meet the healthcare needs of Californians. I think we can take a look at some of the key findings from the snapshot, including sort of the state of behavioral healthcare in the state, such as sort of the prevalence and the rates of need, which may or may not be news to this council. We can dive into a few specific areas of opportunities for improvement that were highlighted in the assessment, as well as some of the key challenges and some of the core services that the assessment focuses on. I'll pause and I'll highlight several communities that were a priority focus area for the assessment, including children and youth, American Indian and Alaska Native individuals, and I think most relevant for this group, individuals who are justice involved. And then finally, I'll conclude by just lifting up some of those key opportunities that across the state to improve prevention and treatment options that are highlighted in the assessment, many of which are a core focus of DHCS's strategic agenda. And of course, we'll open it up for council members to weigh in and to provide feedback, thoughts, reactions. For this assessment, really, which is a tool that is intended to be used for planning and implementation at the state level as well as at the local level. So if we could go to the next slide. So yeah, so we'll just sort of set the table by providing just some key background. So I think, as you know, behavioral health is a top priority of the Newsom administration. I think the COVID pandemic has really highlighted the need to invest in behavioral health services. So this assessment is really intended to sort of guide the planning and the discussion process. It's not a single source of information. It's not a description of this administration's specific positions or plans. It's really just a helpful data point. So I think the department will continue to work closely with stakeholders to implement critical initiatives that are already underway and to develop future policies. So let's talk about sort of what this assessment is and what it intends to do. So what it does is it provides a framework to describe the core continuum of behavioral healthcare services, and we'll touch on this in just a moment. But that framework really helps the reader of the assessment be able to compare, what is currently available in California with what should be or what could be available in California. The assessment aims to review available data, including claims data, national data sets, as well as insights from stakeholders and experts on the need for and on the current supply of key behavioral health resources in the state. It's designed to support the planning for various behavioral health initiatives. I'll touch on these. These include, but are not limited to, crisis service planning, the behavioral health continuum infrastructure program, our responses to new federal funding opportunities, and a proposal for a Section 1115 waiver for strengthening mental health and serious emotional disturbance services. I think, as I mentioned, the assessment really is intended to explore issues for a few populations in focus, including children, adolescents, and youth, the American Indian community in California, and the justice-involved population. We work closely with stakeholders who offered their insights. We work with providers, policymakers, and advocates, and we look forward to leveraging the information in this assessment to guide our ongoing conversations. We can go to the next slide. So just to sort of sketch out that continuum, which is really the framework that the assessment uses to sort of walk through what's available. If we could go to the next slide. So the continuum of care, the core continuum of care that's envisioned is really comprised of fundamental elements of a strong and effective behavioral healthcare system. It is based in national guidance, in the clinical and policy research literature, and expert opinion. I think before we start, getting into what the various services are, it's important to highlight that it's really grounded in key principles. So these principles include beliefs that the behavioral health system and the resources in the state should be person-centered. They should span a full array of services with an emphasis on upstream prevention and community-based care and supports. There should be a specific and intentional focus on achieving equity, and that resources should be culturally responsive and evidence-based. So those are the principles that guided the exploration through the continuum that the assessment does. So as you can see from this graphic, there are about 8 different categories of services. I think it's important to highlight they're not necessarily distinct from each other. In practice, a person might receive services from more than any one category at any moment in time. They might be in intensive outpatient treatment and also receive, peer support services. So the service categories are fluid, and they're designed to reflect sort of, patient flow and patient use through the continuum. We could go to the next slide. So I think, with respect to prevention and wellness, this is, these upstream parts of the continuum are not really typically part of the sort of conventional medical insurance model, but, which is really designed to sort of respond or treat a condition after it develops. But this is a key and vital part of the vision for a person-centered continuum of care. I have to take a second to just brag for Jim Cooler, who you all know well. I think Cal Hope is sort of an example of a prevention or wellness service. I think it's, grew out of a recognition that not everyone needs like a certified or licensed counselor. Sometimes what you need is just a supportive connection and an opportunity to sort of check in on some feelings that you might be having around sadness or fear or stress before it escalates into a crisis. And what Cal Hope has achieved is over 800 million media impressions per month, over 12,000 group counseling sessions per month. The NFL is carrying a full-page message about Cal Hope in its Super Bowl program. The Rose Bowl is doing the same. We've had commitments from the San Francisco 49ers, the LA Chargers, the LA Kings, San Francisco Giants, the Kings in Sacramento, basically every professional sports team in California to put CalHope in their program. I think this interest really speaks to sort of the growing awareness and recognition around wellness, and that mental health is health, and that it's important to reduce the stigma so people can reach out for help. I think, just jumping back to this continuum as laid out in the report, it includes, outpatient services, which, are a little bit more of a traditional service. It includes peer and recovery services. I think SB 803 and the Medi-Cal Peer Support Services SPA is a really useful tool for making further gains in the peer space. And it also includes community services and supports. I think under CalAIM, there are a few opportunities under enhanced care management, community supports, the Housing and Homelessness Incentive Program, which are designed to really help individuals remain in their homes and thrive independently in the community. And this was called out specifically in the assessment as a key pillar of the behavioral health continuum. We can go to the next slide. So these pillars of the continuum, look and smell a little bit more like traditional services. These are more intensive levels of care. We know that these are available today through a variety of funding sources, including commercial insurance coverage, Medi-Cal, MHSA funding, block grant funding, and other state and local funding. So the goal of this assessment was really to sort of pinpoint and develop more granular data and highlight, those key and targeted opportunities to improve access to these services, because we know that while services may be covered under a particular funding source, it doesn't mean it's available to every individual in every community. I'd highlight that the behavioral health continuum infrastructure program is really crucial, especially for these facility-based services. So I'm sure you're familiar, but if you're not, it offers $2.2 billion in funding to qualified entities to invest in mobile crisis infrastructure and to expand the continuum of behavioral health treatment resources. I think I'll touch later on that section 1115 waiver for serious mental illness, which will be crucial to maximize and leverage federal funding for inpatient mental health care. But of course, that's part of a broader expansion of community-based behavioral health services. We could go to the next slide. So I think it's just helpful context to highlight some of the major initiatives that the state is undertaking to improve access to behavioral health care in the state. I think first out of the gate, contingency management really puts the innovation in CalAIM. This makes California the first state in the nation to cover contingency management in the Medicaid program. So contingency management is an intervention for stimulant use disorder and other substance use disorders. It is the highest body of evidence for treating stimulant use disorder, and it's associated with reduced use, with abstinence, and with increases in treatment retention. So DHCS is working with counties across the state to implement this as a pilot program within the Drug Medi-Cal organized delivery system. And we're really excited that this is going to kick off on July 1st. I think, as I've mentioned, the state is preparing to submit what's called a Section 1115 waiver to our federal partners at CMS, focused on individuals with serious mental illness and children and youth with serious emotional disturbance. So this SMI-SED waiver will in many ways be the mental health sort of corollary of the Drug Medi-Cal organized delivery system, which is a Section 1115 waiver really focused on expanding Medi-Cal funding and coverage for substance use disorder. So really importantly, this SMI-SED waiver will allow California to receive federal Medicaid funding for services provided in what are called institutions for mental diseases, or IMDs, which are historically excluded from Medicaid. Finally, a key component of CalAIM is the Justice Involved initiative. I know that there are several council members that participate in the advisory group, including Anita Fisher, Judge Manley, and of course, Executive Officer Brenda Graylish. We're really excited to have the feedback from this council in the stakeholder planning discussions, which would allow DHCS to leverage federal funding under Medi-Cal to really increase services that are provided to individuals in state prisons and jails and youth correctional facilities during a 90-day period prior to their release, so that the pre-release planning and the re-entry periods can be improved, and that they have access to the medical care, the behavioral health care, and the community supports that will help them succeed in the community. We can go to the next slide. So there is, that was just a flavor. I think you'll see here the full laundry list of new and planned initiatives specific to behavioral health alone that this administration is implementing as a top priority. I won't read through all of these, but all of these are significant, and any one of these alone would be notable and worth describing in further detail. These include Medi-Cal initiatives that draw on existing and enhanced federal funding opportunities. These include federal opioid response and block grant funding opportunities from SAMHSA. These include unprecedented investments from the state in terms of state funding. Much of this work is underway already. This assessment will be used to guide and to support sort of the ongoing planning and the ongoing implementation efforts for virtually all of these initiatives. It will also be used to really help facilitate a data-informed process for developing future initiatives as well. So if folks have questions about anything you see on this slide, feel free to sort of pop it in the chat or reach out, and we'd be happy to sort of provide resources to share more information about these. We could go to the next slide. So in the governor's budget, I think you'll see that CalAIM justice package that I mentioned. So this really is sort of foundational. I think the state funding in the governor's budget, coupled with the federal financial participation for covering a targeted set of Medi-Cal services during that pre-release period, coupled with other federal funding that we're requesting to support a lot of the startup costs, the planning efforts, the capacity building for prisons, jails, county social services offices, county behavioral health agencies, to sort of hire staff, train staff, develop policies and procedures, upgrade their IT systems. There's a huge investment in this space, and this is sort of a major intervention that's designed to sort of move the needle and begin to better support this population. I think the foster care model of care work group was convened by DHCS and DSS and has provided key insights into opportunities for developing a model of care that is better designed to meet the complex needs of the foster care population. I think this budget really has other critical elements that are sort of worth calling out, including the behavioral health bridge housing, which is designed to meet that sort of community support aspect of the core continuum and address sort of the affordable housing, the supportive housing, the housing supports that are highlighted in the assessment as key needs across the state. The mobile crisis services would be designed to be implemented as a Medi-Cal state plan benefit across the state. This would leverage enhanced federal funding that's available for a short-term period of time. We look forward to partnering with stakeholders to design that mobile crisis service package. And of course, it's not listed on this slide, but that is, of course, interlinked and aligned with the implementation of 988 through the National Suicide Prevention Lifelines. And I think the medication-assisted treatment expansion program is designed to really continue building on that. I think to date, it's about a $500 million investment in expanding access to MAT and prevention, treatment, and recovery resources and naloxone across the entire state. We could go to the next slide. So what did this assessment find in terms of the state of behavioral health care? So, it really is helpful in terms of providing an overall sort of statewide snapshot of the current state of affairs with respect to the general prevalence of behavioral health conditions and how it's impacting certain communities and populations. Of course, some of this may or may not be news to the council, but I think it's always helpful to have, confirmation of what you suspect or what you know anecdotally. Just across the state, we know 10%, roughly almost 10% of the adult population has substance use disorder. 4.5% have serious mental illness. Over a 10-year period in recent times, the rate of serious mental illness increased by about half. We know there are real inequities and disparities among children with serious emotional disturbance, especially where the intersection of systemic inequalities, leads to children from lower income families and children who are Black and Latino having and experiencing higher rates of serious emotional disturbance relative to other racial and ethnic groups. And so this data is really important for the state and for its stakeholder partners as you design and plan and implement new services and ongoing initiatives to ensure that when they are implemented, that they're reaching the population and the individuals who are most impacted. So this is really important data that the assessment has provided. I think we know, of course, that the public health emergency has intensified stressors and has impacted, mental well-being for probably all of us. We know the impact of the pandemic on mental wellness and on mental illness will be felt for decades. We know that trauma leads to long-term physical illness and mental illness, and we know this pandemic led to, various types of trauma, including death, stress from illness, unemployment, food insecurity, housing insecurity, not to mention social isolation. State or national studies, show that this pandemic is leading to about 50% of adults and youth showing signs of anxiety and depression. This assessment found that over the past 10 years, the suicide rate among youth in California has been rising. And the data is still incomplete, so I don't want to draw hard conclusions, but projections show and preliminary data suggest that the pandemic is playing a role in the increases in the suicide rate among youth. And we know, I think just from national data, that a mental health crisis, mental health crises that result in a trip to the emergency department have increased by about a third for adolescents and teenagers. We can move to the next slide. So as this council knows, justice-involved populations experience greater rates of chronic conditions, including but not limited to behavioral health conditions relative to the general population. We know approximately 1 in 3 adults in prisons and 1 in 4 adults in jails receive mental health services. And so that's why, CalAIM is really critical. I think under the enhanced care management benefit that the Medi-Cal managed care plans are implementing, which has the justice-involved population as a sort of specific and targeted area of focus in conjunction with the community supports that the Medi-Cal managed care plans can offer, which can offer housing supports, housing navigation, and other types of sort of non-traditional social type services available through Medi-Cal. Of course, in conjunction with that justice-involved initiative, it's really a key opportunity to better serve this population. I think, just given that 90% of individuals who are incarcerated meet Medi-Cal eligibility limits, and as you see here, 50% of, or nearly 50% of individuals in California with substance use disorder have Medi-Cal. That, is a really major financing and service delivery platform that we hope to leverage as a game changer for this population. And of course, we know outside of Medi-Cal that individuals with, group health or commercial insurance or individual marketplace insurance often face challenges in accessing mental health services. More than 40% found it was hard to find a provider that accepted their particular type of insurance. And I'm sure, many of us may have experienced that or have had friends or family that have experienced that as well. If we could go to the next slide. So I think what's helpful is to dive into a few key findings from this assessment with respect to some of those pillars of the continuum of care that we highlighted earlier. So, for example, this may not be a surprise, but there's a dearth of psychiatrists across the state, and there's a sort of, inequity in terms of where they're geographically located. I think you can see on this slide that the rate for 100,000 residents ranges from 1.7 psychiatrists in smaller counties to 68 in Marin County and well-resourced counties. So psychiatrists are not equally available across the state. There is, though, some bright spots. We know that what the pandemic did is that it really ushered in an uptake in the use of telehealth as a modality for delivering covered services. DHCS updated its Medi-Cal service coverage and reimbursement policies to really maximize flexibility for telehealth service delivery. This was done during the public health emergency period and under those authorities that are still in place today. And the department's assessing opportunities for sustaining those policies. One study you can see here in this box of community health centers in California found that total behavioral health visits remained virtually unchanged during the pandemic because in-person services, in essence, switched to audio or telephone or sort of video conferencing visits. So this was an unexpected silver lining that we found. We could go to the next slide. So there's a huge opportunity to make progress in the peer and the recovery services space. So we know, especially from stakeholders, how critical it is to have these resources available to individuals with behavioral health conditions. There's not a lot of hard data. There's not a lot of claims data in commercial insurance or in Medi-Cal. The Drug Medi-Cal organized delivery system covers recovery services. We know that there's little utilization of that compared to other covered DMC ODS services, and it's often hard to piece out whether a peer was delivering it or if it was somebody else. We know that some counties have been using peers to deliver services under the Specialty Mental Health Services delivery system, but again, it's hard to piece out when a peer was doing it. And so that's why we're really excited that in Medi-Cal, the peer support services benefit was approved by CMS and will be covered beginning July 1st at the option of every county. So whether it's Drug Medi-Cal, DMC ODS, or Specialty Mental Health Services, every county can elect to cover peer support services. We know how critical it is, for individuals to engage people with behavioral health care needs. It's really helpful to connect with an individual who's been there before, someone with lived experience, especially if you're ambivalent about asking for help or reaching out and getting into treatment. We know it's so helpful with care transitions as well. So after you leave the emergency department or residential, make sure you get to that next outpatient appointment. We know that the California Bridge program has used behavioral health navigators to tremendous effect. I think over about 150 hospitals are implementing MAT and using behavioral health navigators. The rates of follow-up and retention after the ED visit for hospitals that use peer navigators is like double the rate of hospitals that don't. It's such a tremendous asset. And so what DHCS did is leveraged an enhanced federal funding opportunity under the American Rescue Plan Act to invest $40 million in that California Bridge program. We know, of course, though, because it hasn't been a statewide model in terms of covering peer services, that there's a lot of bright spots, and we know there's a lot of local models out there, and I think we look forward to sort of learning more about the uptake and the spread of those promising practices. We could go to the next slide. So the assessment really dives into community services and supports that are really a top priority for the stakeholders that they raised. Of course, I'll just state the obvious: affordable housing was identified as a key problem, and we know this impacts every single person in the state of California. I think really critically, housing supports were identified as a need that's not there today. So for example, this could include, permanent supportive housing models that are based in sort of the evidence-based service model with wraparound services that are provided on a flexible and voluntary basis. I think that is really a critical pillar in the vision of the continuum of care that doesn't exist in a widespread fashion today. We know that counties are delivering full service partnership services that do support and coordinate access to a lot of community services. So we know how critical that intervention is, but of course, maximizing it and scaling it to everyone who needs it is an opportunity for improvement. I think we heard that sober living environments are sort of a key opportunity, as well as longer term adult residential levels of care as well. If we could go to the next slide. So as you know, medication-assisted treatment is sort of the first line of care for opioid use disorder. It has the highest body of evidence for improved patient outcomes. A lot of effort has been invested by state policymakers in terms of funding, service coverage, policy design to expand access to MAT. I think under the Drug Medi-Cal program and Drug Medi-Cal organized delivery system, a lot has been done. Recently, DHCS clarified that every single provider at every single level of care in the DMC ODS program, which covers about 97% of the state's 13 million Medi-Cal members, every single provider has to either offer MAT on site or have an effective referral mechanism to another MAT provider for patients while they're receiving care. It also clarifies billing policies so that MAT can be provided in clinical settings. It can also be provided in non-clinical settings, such as sort of street medicine or mobile units. So we want to make sure funding is not precluded that way. The state leveraged about $500 million in federal funding through the MAT expansion project that has sort of helped fund that California Bridge program that I mentioned. It has invested about $15 million in the Tribal MAT project, which has over the past 4 years implemented a number of specific initiatives designed in close partnership with key tribal and urban Indian stakeholders to expand access to culturally centered opioid and stimulant use disorder prevention, treatment, and recovery resources that are specifically sort of designed to be aligned with tribal values and practices. And of course, we know CDCR has, through their ISUD program, really expanded MAT in the prison system. That said, despite the amazing progress over the past 5 years in this space, there are gaps in access. I think you can see from this slide that there are counties without access to opioid treatment programs, or NTPs, which has a really robust body of evidence. So I think that's another key opportunity for improvement. I think provider education and culture change is another one. I think we know that counties and other providers tell us that even though if a service is covered and it's paid for, a lot of education among patients, among staff, among leadership at providers to really work around some of the ambivalence and the hesitation around the role of MAT in substance use disorder treatment. We know that there's a lot of work to be done there as well. So I think the next slide shows some opportunities that the assessment highlights for residential treatment. So we know that, of course, residential treatment coverage was expanded through the Drug Medi-Cal organized delivery system. Of course, that doesn't mean that access is perfect. 70% of counties report needing more residential service availability. We know that the adolescent population is a particular demographic that has unmet needs at this level of care. And I think we know that 3.3 is a particularly hard nut to crack. I think, it is really interesting though, ASAM is actually proposing to do away completely with level 3.3 because they virtually don't exist across the country. So they're integrating the expectations for level 3.3, which is designed to focus individuals with cognitive impairments and cognitive limitations, and really just ensure that across all levels of care, providers have the capabilities of serving that population. If we can move to the next slide. So with respect to mental health care, it's a little harder, not harder, it's a little less straightforward to identify where the gaps are, because whereas ASAM provides an actual taxonomy or like a standard continuum for residential and inpatient levels, there's not a national standard for mental health. That said, we heard from stakeholders that in particular, there's a shortage of mental health residential treatment, including subacute needs. And so I think this is a really key opportunity for some of those initiatives that I mentioned, like the Section 1115 waiver for serious mental illness, that that will sort of support counties to have additional funding available, not only to expand access to care in residential and inpatient settings, but in community-based settings as well. We can move to the next slide. So crisis services, which was a huge focus of the assessment. SAMHSA, the national, the Federal Substance Abuse and Mental Health Services Administration, describes the crisis continuum of care as consisting of 3 pillars: crisis call centers, mobile crisis response, and crisis receiving and stabilization services. In this assessment, that was expanded a bit to include crisis respite, crisis residential, and sobering centers. So, I would also add that, the Cal Hope program is, what you would think of as a warm line resource. I think under Cal Hope, there have been specific warm lines implemented for communities. Like the California Consortium of Urban Indian Health operates what they call a red line, which is a sort of a peer and counselor run warm line for specializing in the American Indian and Alaska Native population. So I think there are pillars that are of this crisis continuum that are being put into place as we speak. We know through the national legislation, the federal legislation Congress passed, that 988 is being implemented through the National Suicide Prevention Lifelines. We know that in the governor's budget, there was a proposal for mobile crisis to be covered as a Medi-Cal state plan. So DHCS is looking at developing that service on a statewide basis this year to add into the state plan. If we can move to the next slide. So just to sort of dive a little bit deeper into mobile crisis, it's interesting because Medi-Cal today covers crisis intervention services, and Medi-Cal today allows crisis intervention to be delivered on a mobile basis. So there's nothing prohibiting mobile crisis today in Medi-Cal. It's just not explicitly covered. And so for that reason, there's variety across the state in terms of the availability of mobile crisis services and teams, whether they're billing Medi-Cal, whether they're using MHSA or any other funding source. We see in this graphic, counties that are shaded in green may actually have sufficient mobile crisis access. Counties shaded in yellow have some mobile crisis services, but it's not enough according to at least one algorithm. And counties shaded in red report having no mobile crisis services as well. So this is based on a survey that CBHDA provided, and it's a really vital piece of data that this assessment drew upon. So I think what's really helpful, in addition to the mobile crisis SPA that DHCS plans to submit and cover under Medi-Cal, under the behavioral health continuum infrastructure, mobile crisis was really the first round that went out the gate. And so specifically, the department let out or set aside $205 million for counties, cities, and tribal authorities to implement or to expand existing mobile crisis teams. So that's a really huge investment in this space, and we're really excited to see how access expands. If we could go to the next slide. So for inpatient mental health care specifically, of course, we know that, that there's a shortage. So the similar color coding scheme shows counties shaded in green may have sufficient access. County is shaded yellow, have some inpatient mental health beds inside the county lines, but it may not be enough for the general population, and counties in red have no beds. So I think, for this reason, the behavioral health continuum infrastructure, again, has additional rounds of funding specifically dedicated to planning efforts and to what are called launch-ready efforts for acquiring real estate and building brick and mortar facilities for behavioral health care, including inpatient mental health. In conjunction with that seed money, that literal investment into the into the infrastructure for the continuum, the Section 1115 waiver should be another tool that that counties are leveraging. We can go to the next slide. So I think the last piece to focus on really is the populations of focus. As I mentioned, the assessment really highlights children and youth, justice involved, and American Indian and Alaska Native individuals as sort of the key priority populations of focus. As I mentioned, there's a lack of residential treatment for adolescents with substance use disorder. I can see from the quote that's included on this slide, this is a key opportunity for improvement that the assessment is shining a spotlight on. If we can move to the next slide. I think that this council could tell me more than I could share from the assessment what the needs are with respect to individuals who are justice involved. I've touched on a few of those initiatives that DHCS is implementing through Medi-Cal under Cal AIM to better meet the needs of the justice involved population. And we really look forward to receiving approval from our federal partners to be the first state in the nation to cover services for Medi-Cal eligible individuals inside of a correctional setting. With respect to the American Indian and Alaska Native community, we know that they experience fatal opioid-related overdoses at twice the rate of other ethnic and racial groups. We know intergenerational trauma and stressors are sort of key and unique drivers of trauma in this community. We know from stakeholders that there's a lack of prevention, opioid use disorder prevention resources specific to the youth population. I would highlight there is a small bright spot in that using federal opioid response money from SAMHSA, DHCS from the beginning has really prioritized increasing opioid use disorder prevention, treatment, and recovery resources for the tribal and urban Indian population. The Tribal MAT project, it's described on the California MAT Expansion Project website, has implemented a number of initiatives to really increase awareness of opioid use disorder in tribal communities, awareness about overdoses, addressing stigma, distributing naloxone, ensuring ambivalence around medication-assisted treatment is recognized and discussed, and literally providing resources to increase MAT in tribal health and urban Indian health programs, in conjunction with resources to promote community-defined best practices that reflect traditional approaches to healing and to wellness. We can move to the next slide. So we will open it up for discussion in just one moment. I think it's helpful to conclude just by highlighting some of the key opportunities that the assessment highlighted as a conclusion. So clearly there's a significant need across the state for prevention and treatment options. It's not news to this group. Many of these are included in the state's behavioral health agenda and the portfolio that's underway. I think the highlight really underscored the need for a comprehensive approach to crisis services that connects people to the community-based behavioral health care system and not the law enforcement system. As envisioned by county behavioral health agencies and consistent with the mobile crisis SPA, the vision for crisis will include mobile crisis response teams that are available 24 hours a day, 7 days a week, 365 days a year, in conjunction with that 988 suicide prevention and crisis call line. We know that long stays in the emergency department, ED boarding, admin days in hospitals and inpatient psych stays, they exceed individual clinical need. There's strains on the entire delivery system. There are bottlenecks in the supply chain, really. And a root driver is lack of affordable housing and housing support services. And so that was called out in this assessment as a key opportunity for improvement. Those wraparound supportive housing resources was flagged as sort of a key resource for avoiding, ED visits, inpatient stays, long-term residential placements, and of course, incarceration. And for children and youth, the assessment really shines a spotlight on opportunities to meet the growing mental health and behavioral health prevention needs, as well as the treatment needs. I think that's sort of a core goal of the ACEs Aware initiative. It's a core goal of the CalAIM updates to specialty mental health services medical necessity criteria. It's a core goal of the $4 billion investment in the Children and Youth Behavioral Health Initiative. And it's a core goal of the foster care model of care work group. We can move to the next slide. So finally, the assessment describes, challenges and opportunities related to addressing disparities and to ensuring that services are culturally responsive and that meet the needs of people of different gender identities, sexual orientations, races, and ethnicities. I think there's opportunities for really capitalizing on some of those bright spots that we know exist in pockets throughout the state, including, making sure that those bright spots can be expanded and be available on a statewide basis in all communities, and that, evidence-based services are sort of delivered with fidelity to the service model. So I think, just for example, for this council, that could include implementing assertive community treatment as well as forensic assertive community treatment with the focus on serving individuals with mental illness who have criminal justice involvement. That's a potential opportunity under that section 1115 waiver for mental health. And just to pull on that thread a little bit, I think the assessment highlighted the need to better meet not only the behavioral health needs and the medical health needs, but the social drivers of health, including housing and employment for individuals who are involved in the justice system. So, diverting and preventing the incarceration and ensuring individuals who are transitioning from incarcerated settings into the community are really meaningfully and closely connected and engaged with services and supports. That's really that primary goal of the CalAIM Justice Involved initiative that I highlighted. So I think with that, I'll just conclude and say I encourage you to read the report for yourself. I'm sure there's lots of thoughts and questions, and I really look forward to hearing from the council.
Thank you so much, Tyler. What a information-rich presentation. And for folks who are, our council members and folks joining us as participants today, we've dropped the report into the chat that Tyler's been referencing today. So we'll open it up first for council member questions and discussion.
Excellent presentation, Tyler. Just when I think I'm the busiest woman in the state, I'm going to have to think of you. You're covering a lot of ground there, buddy. A lot of important work. So thank you so much. It's really exciting to see all the work that's happening out there to take care of vulnerable populations. I swear I can talk. Thank you.
Thanks, Kathleen. It's really an incredible moment in the state budget and policy environment right now.
And we're very fortunate to have Tyler on the team. And with his expertise and what you've just seen, it's clear that a handing of the baton from me to him will be a very wise choice in having him join this group.
Can I ask a question?
Of course, Judge.
Thank you again, and wonderful presentation. I just had an initial question, and that is when you discuss the 1115 waiver and the request California's made, when will we receive a response?
It's a great question. So let me confirm, you're referencing the 90-day pre-release services for the justice involved population?
Right.
Yeah. So we were hoping to get approval for that in late December when the CMS approved most of CalAIM. They didn't approve it. But what they did do is they let us know that they're interested in approving it. Their approval letter says they're interested in approving it. And we continue to have really productive and sort of optimistic discussions with them. I can't give you a precise date, but I wouldn't be telling you that we're feeling optimistic if we weren't feeling optimistic. So we hope it's soon, and we're, I hope to have an update soon, is what I would say.
That's great to hear. Also, is there a, is on your website, or can you point me to where all these funding opportunities are gathered together in one place for example, in increasing, facilities, all the different, you've gone over them, we go over them again and again, but is there, I'm asking repeatedly, where can you find a list of all of them that counties should be accessing or trying to access or make grant applications to? I know a number of counties, there was a planning grant, and that, I think the closing date was in November, something like that, and many counties missed it. And I had raised it with judges that they should be urging their counties to apply. And I just wondered, is there one place where all of these are listed?
Yeah, thank you, Judge Manley. So I just popped into the chat the website for the $2.2 billion in funding available to grants through the Behavioral Health Care Infrastructure Program. And then DSS in partnership is doing the Community Care Expansion Program. So that website is the best go-to place for those, the rounds of the grants that you referenced. But that website doesn't talk about, for example, the 1115 waiver, that we just talked about a moment ago. But if you're talking about grant funding for counties, that website's the best website.
Great, thank you.
Hey, Tyler, it's Tony Hobson here. I'm Behavioral Health Director in Plymouth County. It's an exciting time to be in county behavioral health for sure. It's also overwhelming with all the changes that are coming. You can probably relate. One of the struggles that many counties have is locating inpatient psychiatric beds. And that could have been my quote. It could have been one of my peers' quotes, but there is a practice of, and I risk saying this, a discriminatory practice of not accepting people from the jail into psychiatric hospitals. It's nearly impossible to get somebody who's incarcerated in a county jail in a psychiatric hospital. And they will tell you it's because they're incarcerated, or they will tell you we can't discharge to a jail. So what is the department's position on how to address this with PUFs or other IMD type psych facilities?
The issue of the psychiatric inpatient hospitals refusing to accept individuals transitioning from a jail.
Correct. So they're in jail.
Yeah.
they meet criteria for a psychiatric placement on a 5150 hold or a 4011.6, and you can't, it's nearly impossible to find a facility to accept them.
Got it. Thank you for raising, and that may be your quote, but if it's not your quote, then clearly it's widespread. So I don't have sort of a ready answer for you, but what I can do is loop back. We'll investigate that, and we'll probably reach out to our inpatient mental health provider stakeholders to learn more about what might be some of the root drivers of this issue. But thank you for raising it.
Yeah, and I raise it for a couple of reasons. One, if the county is like in my county, we're small. We are the treatment provider in the jail. We see somebody that we know is not appropriate to be in jail. The judge can order involuntary medications, but that's up to the physician to whether or not they want to administer the involuntary med. If your jail's not a designated treatment facility, you can't involuntarily medicate. And then comes in question competency, right? So all of a sudden now they're declared incompetent because to stand trial, because we can't get them to the level of care that they need. And so it impacts DSH, it impacts us, it impacts the sheriff's departments. And I feel like it's a discriminatory practice against a segment of the population that isn't right. And so I feel like there needs to be some oversight, some follow-up with that. But so thank you for listening.
No, thanks for raising it. And I know through the SMI SED waiver, we're interested in, highlighting and acting on opportunities that the incompetent to stand trial work group may have identified that could be applicable. So to the extent there's an IST, lens here, I think that we know for this administration, that's really important. So thank you for raising that, Tony.
Any other council member thoughts or reflections?
I'll let Anita go first.
Go ahead. You go first.
Go ahead, Anita.
Okay, thank you. Hi. Okay. So that was just a wonderful report. It's so exciting. Again, I always coming from that family member perspective, and all the family members that I currently work with, this is what we want and what we need to see, and the money's there, and but on our level, what we always hear, there's always a shortage of. I mean, where is the money for increasing the workforce, the professionals that can support these programs? Where is the plan about, we always hear about the beds. So where are these beds going to go? Just in my county, an article in our local paper that they just nixed some beds for a particular community, did the not in my backyard, the whole NIMBY thing. So where is the plan in order to make this happen throughout the different communities? So I guess that's my question. Yeah.
It's a terrific question. Local ordinances and zonings, I think, are an issue. I think this administration has tried to use the state's platform to mitigate local municipalities from, preventing the expansion of building or service facilities. I think with respect to where are the beds, I think the $2.2 billion in the behavioral health Continuum infrastructure project, they're not going to come tomorrow, but they're going to come. So I think that is in the pipeline, and that's the core purpose of that investment. But where are the people it's an excellent question. There's a behavioral, this wasn't in the presentation, but we know that there's a workforce shortage. There's a behavioral health care workforce shortage. And so that is something that the state is aware of. We know the counties are aware of it. The HHS agency is aware of it, and it's an issue. I think we're exploring opportunities, and we hear you. Thank you for raising it.
Hi, Tyler. This is Chris Edens from Department of State Hospitals. I mean, that was an incredible presentation. It was a lot of information, and I've heard bits and pieces from other presentations, but it's still a lot, and I'm learning. so much with every presentation. And so I just, again, I want to commend you and the DHCS team. We are definitely in this sort of historic moment in time, but just sort of following on what Anita was sharing is that I do think, and just sort of flagging this for Brenda and for the CCJBH team, is that I think what would be really, really helpful is to see some sort of crosswalk as to here are some gaps and sort of recommendations in terms of our continuum, and then how and where do all these sort of like funding sources align, and how are these different opportunities across all of the different departments addressing these portions of the continuum or the recommendations that have resulted from this this assessment. Similar to DHCS, DSH, while we're just like a small, tiny portion of the criminal justice behavioral health population, felony IST, it is a huge issue. And we have funding opportunities that have been presented in this year's budget that you mentioned, Brenda, as well as some other opportunities that we had in prior years, the diversion program and community-based restoration. I think it's incumbent upon us to be very mindful about how to ensure that we're not duplicating efforts, that we're really aligning efforts and filling in gaps where we can, and being very strategic about our funding. So I know that CSG has done some work in this space, just in terms of trying to create an inventory of here's all the ways that you could potentially as a county look to funding this particular strategy. I'm wondering if we might employ them to do more of that in terms of crosswalking all of these enormous, incredible opportunities, so that we can kind of see that menu and help us with our planning.
I agree. I think that'd be really helpful. I think the assessment itself intentionally did not want to have a rebuttal, for every opportunity for improvement. We didn't want to say this is what we're doing, because we didn't want it to seem like, this case is closed, right? But I fully agree. It was really designed to highlight opportunities. And I fully agree with you that across the HHS departments, it would be super helpful to have that inventory. I think whether it's agency or CHCF, I think that would be a really helpful resource.
Yeah, or something that we as a council could help support, specifically as it relates to the criminal justice behavioral health population. That would be an incredible resource.
Thanks, Chris. Judge Manley.
Yeah, just two other things I would like to ask you, two questions. I just want, we have a sobering center, which we use as a triage center out in the community. Is the definition of a sobering center, does that permit to the use of it for behavioral health, mental health treatment, and transitioning into the community mental health system? Or, a sobering center traditionally has only related to substance abuse. What we are utilizing it for is for people who are mentally ill, and as to avoid booking into jail. And I would like to see more of them developed. Will that be covered in that way? Or does it have some definition that would preclude using it, say specifically for mentally ill individuals?
It's a good question. So I think there's a few different ways. It really depends on how that facility is sort of licensed or certified and how they're trying to receive funding. So just as an example, under Cal-AIM, the Medi-Cal managed care plans have the opportunity to cover what are a service called sobering centers. And so that, by definition, that is limited to individuals who are under the influence of a substance. So for individuals, as you're describing, with mental illness who are not sort of, inebriated or intoxicated, probably wouldn't be coverable for them just because it doesn't meet the service definition. That said, I don't know about the sobering center, but under Medi-Cal, there are crisis intervention services and crisis stabilization services that are covered under Medi-Cal. So to the extent that the service is meeting individuals with mental illness who are experiencing a crisis, that could potentially be another way to bill it as a covered service and receive reimbursement. I think under the, counties operate, and Tony could speak to this better than I could, counties operate mental health services funding, mental health block grant funding. So I think counties have also flexibility using those pots of money, which have a little more flexibility than Medi-Cal, which can be pretty restrictive. So counties at their discretion could fund something like that, even if it doesn't meet a Medi-Cal definition, if that's helpful.
What if it's a co-occurring client? I mean, most of these individuals, I mean, I see them every day, that 90% of them are always, they're using drugs when they're not taking their medications. I mean, wouldn't that be covered?
Yeah, so just if you look, and I'm happy to sort of share this with you, I think under the, so again, a few different like umbrellas here, under the Medi-Cal Managed Care Plan Sobering Center Community Support Service, it would, if it's co-occurring and they are under the influence of SUD, but of course have comorbid mental health conditions, that would be covered, yeah.
Great. Thank you. Finally, I just wanted to ask you about what I have noted in my county, and I'm talking to judges in other counties to see the same thing, that the often families, when the child or a family member is really decompensated, they don't want them to go to jail, they will take them to the emergency room of a hospital. And the same is true, I have found, with the individuals I work with who are homeless and mentally ill. There comes a point in when they themselves want a time out from the chaos in there, and so they will go to an emergency room of a hospital. Are you working with them so that when this system we finally get it developed so it works, that they are included? Because, for example, I've noted there's legislation that requires hospitals now. We had a presentation, I think, a couple of years ago, that when the individual is homeless, they must provide a meal, they must provide clothing, they must give them transportation to a place where they'll be safe. There are all these requirements, and I'm just hopeful that is built into the system, into Cal-AIM or whatever one wants to call it in the end, so that because what happens that is most concerning to me is that people go to the hospital emergency room because everyone's trying to avoid them, including the police will take them there, from going to jail. The emergency room puts them back in the streets, within hours, and then they're back in jail, you see. And that to me, is, they went there voluntarily. Nobody forced them to go there. They were seeking help and they end up in jail. They get out of jail, they go right back there, and we just go around in a cycle. So I just suggest it's something that we need to address.
Yeah, thanks, Judge. Absolutely. I think I think the best sort of sector of the system would be like the crisis service system would be designed for that. And I think this assessment really called out the opportunities to improve the various services in that crisis continuum of care. And so in the $2.2 billion in the behavioral health care infrastructure program, that could be used by counties and the cities that are applying to build new facilities for crisis stabilization. So whether it's an individual themselves or a family member, if they need a timeout, that would be the place they would go to instead of the ED. So that's literally the purpose for that. And then in terms of expanding mobile crisis teams, again, funded under BCHIP, it's so that instead of calling the police or going to the hospital, there's a hotline in that county and people come. It's a peer, someone with mental illness or lived experience comes, along with licensed counselor or LCSW, they come and they provide mobile crisis services. They respond. Maybe that timeout happens in the home. Maybe it happens over that afternoon. Maybe that individual does go to a crisis receiving facility. So the expansion of mobile crisis response teams funded under BCHIP is exactly designed to do that. And then to fund it on a sustainable basis, it's that Medi-Cal state plan benefit that DHCS plans to cover, so that those services are actually reimbursed under Medi-Cal every time it happens.
Thank you.
That's the vision. It's a long, we have to get there.
Great one. Great one.
Okay, well, I'm looking at the time. It's about 4:11 right now. So how about we move to public comment? And again, just reminding everybody to keep comments to 3 minutes. Monica's going to be kind enough to time that for us. And it looks like we have one hand raised right now. Monica, can you unmute Andrea?
Okay, Andrea's unmuted. She has 3 minutes.
Thank you. Hi, thank you, Brenda. Hi, Tyler. My name's Andrea Crook. I'm the Director of Advocacy with Access California. And I just put on my headphones because we're having a new roof put on. So if you hear something really loud, I'm okay. I'm safe. I wanted to take this opportunity. I'm not sure. I know you're fairly new, but I'm not sure if you're familiar with Cal Voices. I'm Director of Advocacy for Cal Voices and Access, and we're a peer-run organization. And I printed out this report earlier this week. I haven't had the chance to read it, so I really appreciated your thorough presentation. There was one part that I wanted to go over, though, and it really had to do with peer support. In the report on page 50, it says at the time of this report, no data are readily available on the extent to which peer support and recovery services are available in California. And I think this really speaks to oh, I didn't get her name and she hopped off, but there's opportunities for collaboration and sharing information. One thing that we did, which was funded by the Oversight and Accountability Commission at the end of 2020, was write a State of the Community report, where we collected hundreds and hundreds and hundreds of surveys. We did qualitative and quantitative research. We did hundreds of interviews in person with leadership and clients across the state. That really speaks to the state of peer supports in California. After 2004, when MHSA was passed, there's now a mandate for counties through MHSA to hire peers. So I really wanted the opportunity to talk about that. I know I only have 3 minutes. So what I'm going to do is I'm going to plop this report into the chat box for everyone to review. And I just want to, close with really talking about how important it is for us to utilize the voices of those with lived experience when we're creating these plans moving forward. And I know that we're stronger together, and we need to utilize all the tools in our arsenal. So I thank you for the opportunity, and I look forward to hopefully meeting you someday in person when we get through this, Tyler. Thank you.
Let me just add an appreciation to Cal Voices as a great peer partner for us with the Cal Hope program with our peer outreach. So Andrea, thank you.
Thank you. And UCLA has been so wonderful to work with too. So thank you.
Hey. Monica, next caller.
Hi, can you hear me?
Yeah,
Hi.
we sure can.
Hi, my name is Paula Neal Ressa. This is my first time listening in on one of your meetings. I'm with a nonprofit in South Orange County called Family Assistance Ministries. We provide services to homeless and low-income folks through shelter, food, and a variety of case management services. I wanted to just find out if someone had mentioned halfway through the presentation, I think Tyler, you did, that in the chat was going to be put a good website to find all the funding opportunities, and it hadn't gone into the chat up until now, and I was hoping we didn't forget that. And then the other thing is, would we be able to get a copy of the presentation? because it was very information rich and I took a million notes, and I would love to see a copy of the presentation. Thank you very much for all the information.
Yeah, and actually the presentation is on our website, and I believe the link is in the chat. I'm wondering if maybe you're not getting the links, because I see where Tyler did put that link in the chat, so we can.
And I actually see, Brenda, that I actually only sent it to host and panelists by accident.
Oh, that's what it was. Okay.
But
Got
it
it.
looks like Emily just copied it. So
Got
Paula,
it.
if you're able to see that infrastructure building Cal HHS link, that would be the link for the grant funding.
Perfect. Thank you very much.
Oh, great. Thanks. Glad you flagged that, Paula. Okay, great. And it looks like we have a few questions in the Q&A. I'll just pop those up right now. One question is, DHCS working with state hospitals to include IST populations in the Justice Involved Advisory Committee?
It's a great question. So we are partnering with DSH, the Department of State Hospitals, in the advisory group for the Justice Involved Initiative.
Great. And then another question, for those counties that may have sufficient mobile crisis teams, so the green counties that were in the chart, do we know what the response time would be with the current fleet of teams?
I suggest that you read the assessment and see if it's in there. I don't know offhand whether that data is included in the assessment or was included in the original data source that the assessment relied upon, unfortunately.
Okay. And then a question from Stephen McNally. And I think it says, when MHSA plans bill and get reimbursed by Medi-Cal or a commercial managed healthcare plan, is the money returned to the MHSA plans, and how is this tracked? This is over and above FFP shown on plans. And I'm wondering if it's when county plans use MHSA to match for Medi-Cal, maybe? I'm not quite sure. Maybe Stephen, if you're still on, if you want to raise your hand or we can unmute you, he might have popped off. Yeah, I think he had to leave. Anyway, I'm not quite sure the question. Does it make sense to you, Tyler? It's not making sense to me.
No,
Okay.
I'm not sure.
So say if MHSA is used for match, then I know, the FFP goes back to the county, and that's all shown on the cost report. But things will be changing with payment reform, right? So, okay. Can the Department of State Hospitals Diversion project gain access to the Meth Contingency Management pilot?
So the Contingency Management pilot is a pilot program where it would be a covered service available under the Drug Medi-Cal Organized Delivery System. So today there are 37 counties that participate in the Drug Medi-Cal Organized Delivery System under Medi-Cal. So it would be limited to those counties that choose to opt into the Contingency Management pilot. And then in those counties, it would be limited to the DMC certified DMC ODS providers that choose to participate in the pilot as well. So I don't believe the Department of State Hospitals is a DMC certified provider. So I think the answer is probably no.
And then another question relating to the, I think it's related to the survey or the work that was done to capture the information for the assessment. How was this information translated and disseminated to the Asian Pacific Islander communities in Los Angeles? Was there an outreach to local API nonprofits for assistance to reaching out to the older traditional folks in our API communities, especially when incarceration is such a taboo issue within the API community as it is? Has appropriate training been looked into this before outreach? And then also mental health issues as well are a big taboo issue in API communities.
Got it. So I know that the assessment was, it was published, and there were sort of statewide presentations to help share the assessment. And if there's any contact information, I can find out more information about translation and specific outreach efforts that may be taking place or available.
Thanks, Tyler. I feel like I'm just shooting you with questions. Another one, I'll lob them over the plate. You just knock them out of the park. Mobile response is now being funded by county DHCS grants, MHSA innovation funds, and City CARES Act funding. Is there a chart that shows where CalAIM is and the different funding sources, MHSA realignment, FFP overlap, are singularly focused or can be used as matching or leveraging by combining areas? Oh, and here's where he says he had to pop off, but we can get this for the minutes.
Yeah, it's a great question. I don't think DHCS has not developed such a chart today. There may be one available that I'm not aware of, but there are definitely some grant funding opportunities available today, I think through the state budget process, as well as through that crisis care mobile units grant funding that I mentioned. I think what's really helpful to highlight is that the crisis care mobile units grant funding rounds were really designed for planning and implementing or expanding the teams, really sort of like startup money. But the design or the purpose of that isn't ongoing financing or ongoing sustainability. So I think that's where the Medi-Cal service coverage for mobile crisis services comes into play, because that is designed to provide ongoing reimbursement for when the services are provided by the teams that have been established by that grant funding. So that's sort of how those two funding sources intersect. And of course, counties manipulate and use Mental Health Services Act funding and other funding as well to deliver the services to their residents.
Great.
Brenda? Sorry, this is Chris from State Hospitals. I apologize, I didn't catch this before we moved on to the next question, but can I go back to the question around can the DSH diversion project gain access to the meth contingency management pilot? Just a point of clarification there that the Department of State Hospitals allocates the funds to the counties. Typically, it's county behavioral health who we are contracting with to support that program, and we don't have any restrictions in terms of if a county entity could have access, to the meth contingency management pilot, to the extent that they could leverage that to sort of supplement or add to the services, that would be acceptable from our perspective. So the only sort of restriction is that we do in some of our the original pilot of the program, we do require a 10 to 20% match. And the match source cannot be another sort of state funded program. It's got to be some sort of local funds. But other than that, if you're just adding to the sort of like menu of different services to supplement and create and operate your diversion program, from my perspective, I think it would be okay.
Thank you for clarifying. I wasn't aware of that program, so I don't think I was fully tracking what the question was asking. So thank you.
Not a problem.
I would hazard to guess that most of the DISH IST funded programs are DMC ODS counties, right?
Got it.
Because it's usually the larger counties that have more, and the larger counties are contracting with DSH for the IST. So I think if they are ODS, then the contingency funds would be useful. Sure.
Yeah, that'd be good for us to crosswalk the counties, which counties participate in that pilot.
Great. Well, I am looking at the time right now, and we're at about 4:24, and I think most of the questions have been answered, although there's a couple additional links. Andrea put the link to her report into the Q&A, and it looks like David added in his link as a link, another helpful link on funding as well. Thanks, David. And then it looks like just some follow-up or, from when on the API questions that Tyler already addressed. So with that, if my team can pop up the last slide on our upcoming events, I guess first to say big thank you, Tyler, for coming here today and this really thoughtful extremely informative presentation. Great job. And thanks for answering all the questions for us today, and appreciate all the time you've taken with us. So I think with that, I didn't know if we went a little bit longer. I think you stayed a little longer than we were anticipating, but it was super helpful information.
Yeah, of course. Thanks, Brenda.
Great. Just upcoming events. So our next full council meeting will be on April 29th. Again, looking for the SHORE program to come present to us. And then in February, we have our 2 work group meetings, our juvenile justice work group meeting on February 11th, and then the diversion and reentry work group on February 18th, both of those occurring from 1 to 3 p.m. Also just want to do a little plug for our housing webinars that we've been doing with council and state governments from the housing report. Webinar 3 will be held on February 24th from 12 to 1:30, and that will focus on common practices for connecting to and using housing as a strategy for diversion and reentry. As always, our website, please visit our website for our latest and greatest information. We do work hard to keep that website updated, and you can also sign up on that website to get on our listserv. We send out emails every Friday with the latest and greatest in our information, our council business information, as well as any relevant work being done by other of our partners and our other state agencies. Just try to get information, reports, webinars, meetings, anything we can to get out, just to keep everybody posted and on top of the latest and greatest. With that, I want to say a big thank you to our council members for taking the time to be here with us today, to all of the participants for spending your afternoon with us, and a big thank you to our CCJBH staff who work tirelessly behind the scenes to make these presentation possible, and they do magic behind the scenes. So with that, I think we can call this session to a close and wish everybody a happy weekend, and stay well.
Thanks, everybody.
Thank you.
Thank you, everybody.
Thank you.
Bye-bye now.
Thank you. Great job.